Welcome to the Long COVID podcast with me, Jackie Baxter. I am really excited to bring you today's episode. Please do check out the links in the show notes where you can find the podcast website, social media and support group, as well as a link to buy me a coffee if you are able. You should not rely on any medical information contained in this podcast and related materials in making medical, health-related or other decisions. Please do consult a doctor or other health professional. I love to hear from you. If you've got any suggestions or feedback or just want to say hey, then please do get in touch. I really hope you enjoy this episode, so here we go. Hello and welcome to this episode of the Long COVID podcast. I am absolutely delighted to be joined this evening, or I think this morning for you, by Lauren Stiles, President and co-founder of Dysautonomia International. So no surprises what we're going to be talking about in this episode. So welcome to the podcast.
Thanks so much for having me.
I'm really happy to have you here. So to start with, would you mind just giving me a brief introduction of yourself and what it is that you do?
Sure. So I am from outside New York, outside the city, and I was an attorney and a sort of healthy, athletic, functioning person who was not a sick person for the first 31 years of my life. And back in 2010, I had what seemed like a mild infection and then a really bad snowboarding concussion within a month of each other. And I woke up the next day and had full-blown disaster health, which of course I didn't have language for that. I didn't say, "Oh dear doctor, I have dysautonomia" on day one. I was just like, what is wrong with me? I couldn't stand up without fainting. My GI tract stopped working. I had severe shortness of breath to the point that I was turning kind of grayish purple, and just everything seemed to go wrong at once. And it took 2 years of bouncing around to different doctors. And eventually I was diagnosed at the Cleveland Clinic after a very, very large number of misdiagnoses, diagnosed with POTS caused by Sjogren's syndrome, which is a common autoimmune disease that causes autonomic neuropathies. And it was actually triggered by this kind of concussion and maybe the infection the month prior. So it's a little confusing, right? How does a concussion trigger POTS? So maybe that's another podcast in itself. But in any event, I've been part of the dysautonomia sort of chronic illness advocacy community for over a decade. After my own diagnostic battle, journey, I actually have a slide lecture I call Adventures in Misdiagnosis. And I think a lot of long COVID patients can probably relate to that. That I started Dysautonomia International with some like-minded parents and patients and doctors who really wanted to advance this field and push the research forward and provide structured support groups and clinician education training programs to really just move us forward, because it felt like we were kind of paddling in a sinking boat 10, 12 years ago. It still feels like that sometimes today, but in the immediate term, it always feels like it's not fast enough, nothing's happening, we're not being helped. But if you look at over the 10 years that since Dysautonomia International has existed, we have had dramatic improvements in the diagnostic delays are reduced. There are support groups now in all 50 US states and 60 other countries. There's doctors all over the world who are starting to get into this. That, not necessarily every country doesn't have a fantastic dysautonomia center, but a lot of them are starting to get into this. And so we've made progress in that 10 years. And then along the way on my personal journey, starting out as a lawyer turned unintentional patient, right? I started getting into research and sort of pushing ideas like, well, what if we did this? And what if, can someone study this? And at some point you realize like, this field is so underdeveloped that even a lawyer could actually do some helpful research. So I started doing actual research. I had a marine biology background before law school. And I ended up becoming, to my surprise, invited to become a research assistant professor of neurology at Stony Brook University in New York. So I don't have an MD or a PhD. I'm a JD, which doesn't really count much in the medical field. But I've been able to work with some really great clinicians and other researchers to really try to set out things like the world's largest POTS research registry, immune phenotyping studies, the first immunotherapy clinical trial in POTS, and other things. So between Dysautonomia International and the Stony Brook research role, I'm pretty busy for a complex chronic illness patient, but I'm very fortunate in that I got access to immunotherapy because I had Sjogren's syndrome. And that was the game changer for me. Like many assorted dysautonomia POTS patients, I had all the things, right? They diagnosed IBS and fibromyalgia and mast cell activation syndrome, and your joints are a little flexible. I didn't get the official Ehlers-Danlos syndrome diagnosis, but I have sort of some joints that are abnormally bendy for an adult woman who's not a gymnast. And so anyways, I got all these diagnostic labels, but I knew that there had to be sort of some underlying thing. You don't wake up and suddenly have 15 different diseases. So for me, that underlying thing appears to be Sjogren's syndrome, which is a systemic autoimmune disease. And so when we treated the Sjogren's with IVIG, which is intravenous immunoglobulin, my POTS and mast cell symptoms and GI dysmotility and neuropathic pain and sort of all the things got dramatically better. And I'm not saying this is the answer for everyone and it's going to make everyone dramatically better, but it was something that allowed me to have more energy to focus on advocacy. And, even with IVIG, I'm not cured. I'm not like 100% what I used to be, but I kind of think of myself as like, I'm a really high functioning sick person. So.
No, that's wonderful. And you sound like you achieve a lot for even a non-sick person. So that's amazing. Yeah, it's really interesting talking about the whole sort of diagnostic journey and, with long COVID, we're sort of a long way back in the process in that, but some of the things you were saying about the process of, all these sort of labels and new things, and you think, well, a label's not particularly useful unless you can do something with it.
Yeah.
But certainly, yeah, it's interesting about all these things that I now read research papers for fun when I can. And, I now understand what dysautonomia is. And it's really interesting how suddenly this kind of becomes your world, isn't it?
Yeah, it's easy to go down the rabbit hole. As patients, we want patients to be, and as patients ourselves, we want to be as informed as possible, especially when it's very hard to find doctors who have the expertise they need to treat you, right? If you had a common thing that every doctor knew, you had a broken arm, you wouldn't sit around reading journal articles about fixing broken arms because you'd be able to find a doctor who could do that very easily for you, and you would get on with your life, but when you have a complex chronic illness that is very hard to find good clinical care for, in large part because we don't really have the research hasn't really been done to tell us like what is the best way to treat this, so you do end up becoming a bit of your own expert as a survival skill, right, to help you. And I really think that's how I ended up becoming a researcher. There was no one studying my disease there. POTS had some researchers and Sjogren's had some researchers, but absolutely no one was studying the relationship between these conditions. And so I started doing that. And I see lots of long COVID patients jumping in on the research. It's amazing. I really think long COVID is possibly the first disease in history where the patients did the research first and really put the disease on the map and are playing a very large role in directing and coordinating like what are the research priorities here. And it is unique in that way. I should also mention, so you're a long COVID podcast. I got COVID in February of 2020 because I didn't already have enough health issues apparently. And it was a pretty standard, viral infection, stay home. I didn't need to go to the hospital. I wasn't intubated or anything like that. But I had lingering symptoms for over a year. In the very beginning, we weren't calling it long COVID. I was just like, I'm having a post-viral flare of my POTS and Sjogren's, which is really how I thought of it. But obviously, there are lots of people with pre-existing conditions who got COVID and whatever they had got a lot worse. And some of them have not bounced back, at around a year. I kind of got back into my baseline sick, like the normal chronic illness stage I was in. But I see this really big diversity of a lot of the conversation around long COVID has been about people who were healthy and then suddenly got really sick, because that's shocking, right? When you're young and healthy. But I think we also need to talk about all of the people in the disability, whether they consider themselves part of a disability community or not. Sometimes people have chronic diseases and they don't think of themselves as disabled. But if you had a chronic health condition that you were trying to manage and struggling, and then all of a sudden you got COVID, and now you have long COVID plus your other stuff. And that's a good section of this long COVID community, I think. And the research data has shown that out, that a lot, there are probably a lot of underlying diseases that might be risk factors for long COVID. So it's complex, to try. It's hard enough managing long COVID by itself, but long COVID plus some other underlying diseases is definitely a challenge. So
yeah, I think that's a really good point, actually, because it seems like, again, this is obviously probably anecdotal because it's what I've seen on like Twitter. But, you tend to see that either it's the I was completely fit and healthy and this has hit me out of nothing kind of cohort, if that's even the word. And then there's also the other sort of flip side of it, where it's someone, like you say, had something pre-existing. Maybe they were managing it quite successfully, or maybe it was a bit more of a thing. My words have gone, sorry. But yeah, and then they've got COVID on top, and sort of long COVID plus, or what they had before plus, however you look at it, and it's really interesting, isn't it?
Yeah, I think looking at the diseases, the existing diseases that COVID worsens, actually gives us a medical clue as to the mechanisms of long COVID, right? We see worsening of POTS, worsening of ME/CFS, worsening of autoimmune diseases, worsening of diabetes, right? So these things have a common underlying thread of, immune and metabolic dysfunction. And certainly in the POTS community, and I want to emphasize, dysautonomia isn't just POTS. Sometimes, especially if this is new vocabulary to some people, maybe we should actually step back and talk about what is dysautonomia, because I'm sure your listeners have a wide range of expertise.
We'll be right back. I'm interrupting myself for a second to tell you about long COVID breathing. The fabulous Vicky Jones and I have teamed up to bring you long COVID breathing. We are both passionate about sharing our expertise and experience of the breath and how incredibly helpful that can be with long COVID. We've worked together to develop a course that is specifically tailored to those with long COVID. It's a 6-week course with 12 sessions, all delivered online. The community feel and learning that we're all sharing is such a joy. To find out more information and to sign up for our courses, workshops and other shorter sessions, please check out the link below, longcovidbreathing.com, or email longcovidbreathing@gmail.com to start your breathing journey with us. Yeah, totally. Yeah, that was actually my next question. So, yeah, absolutely. Because there's sort of different types, isn't there? Which is why I think people often, maybe they think, oh, I don't have POTS, so therefore I don't have any form of dysautonomia. But it's not like that at all, is it?
So dysautonomia is actually not a diagnosis in itself. It's an umbrella term, sort of like infection is a big umbrella term. And if a doctor says to you, you have an infection, your job is to say, what kind of infection? Where is it in my body? Is it going to get better? What's the prognosis, right? So if someone says you have dysautonomia, you should be asking, what type of dysautonomia? The reality is that many doctors do not have the skills and diagnostic tools to distinguish. It's actually good that they've recognized you have a dysautonomia, you have an autonomic nervous system problem. But so be aware that being told you have dysautonomia, while helpful, doesn't really pinpoint the diagnosis, which is important to do because there's different treatments for different types of dysautonomia. So what is dysautonomia in the whole? It's a problem with the structure or the function of your autonomic nervous system. So if you remember back to high school biology, your autonomic nervous system in the simplest terms, you have the sympathetic branch, which is your fight or flight response. It raises your heart rate, it raises your blood pressure. This is when you're about to give a speech and you're nervous and you get the butterflies in your belly. That's your sympathetic nervous system kicking into high gear. And then the other branch is the parasympathetic nervous system, which is the Netflix and chill, I call it. People would say rest and digest, but I think the modern version of that, it's the Netflix and chill branch. It helps you with sleep, relaxation, it's anti-inflammatory, it's sort of pleasure, things that are yoga is like the thing that triggers your parasympathetic nervous system to function, to increase. So that's an overly simplistic view of it. There's actually lots of crosstalk and feedback in other parts, but those are the two main branches. And so what we see in long COVID and in most chronic diseases, not just long COVID, is that people have, generally speaking, right? There's always the exceptions to the rule, but the general concept in long COVID is that people have too much sympathetic nervous system activity. So too much of that fight or flight, heart rate, blood pressure getting all wacky, and GI motility is impacted by the autonomic nervous system too. And they have a reduction in their parasympathetic nervous system. So they're losing the benefits of that rest and digest and anti-inflammatory and sleep function. So why does this happen? Well, there's many different ways your autonomic nervous system can go wrong. Some people have an actual neuropathy where the autonomic nerves have been damaged and are now partially missing. If you had no autonomic nerves, you wouldn't be listening to this podcast, you'd be dead. But most types of post-viral dysautonomia, I want to reassure people, post-viral dysautonomia is really not usually fatal. POTS is not fatal. We have no reported cases of anyone ever dying from POTS. And believe me, sometimes patients think, well, they're just not telling us, and it's not like that at all. If POTS was fatal, every POTS researcher would be putting that in their journal articles and their grant applications because they'd get more research funding, So it's not fatal, but it's very debilitating, really, really debilitating. So the different types of dysautonomia that we commonly see in long COVID would be POTS, postural orthostatic tachycardia syndrome, which has its own diagnostic criteria. Then also we see orthostatic intolerance, which is essentially POTS without the tachycardia. I think it's probably the same disease, but it has a different diagnostic pathway right now. Those are the two most common. I'd say POTS is probably the most common, OI, and then less commonly we see orthostatic hypotension, which is a more severe dysautonomia than POTS or OI, and it's an acute drop in blood pressure like each time you stand up, and it's considered a type of autonomic failure. Usually only seen in older people, but in severe, like if you had pretty bad nerve damage from COVID, you could get an OH diagnosis. And then there's other types, hyperhidrosis, which is really excessive sweating, like pathologically excessive sweating, hyperhidrosis. And then we also see people with GI dysmotility problems like gastroparesis or esophageal dysmotility, and that's all regulated by your autonomic nervous system. And then in really not common, but also part of the autonomic nervous system, we might see bladder dysfunction. So your bladder muscles and all your smooth muscles in your body, not the arms and the leg muscles, but the organ muscles and the blood vessels and the glands are all regulated by the autonomic nervous system. So you can get bladder dysfunction. Dry eyes and dry mouth is a dysautonomia symptom because your tears are regulated and your saliva glands are regulated by the autonomics. Anyways, yeah, it's confusing when you're new to it. It's a lot to learn. And I think even for doctors, because I think that's part of the reason why we don't have a lot of autonomic experts, is because this is the type of medical problem that is cross-discipline. I think a lot of doctors these days, if you're going to be a specialist, you become a pulmonologist and you become like the expert in lungs, but it's harder to find doctors who have expertise in all of that stuff I just mentioned, right? Blood vessels and heart and pupils and saliva and bladder and kidney function and sweating. And it's a lot.
Yeah, it is. Yeah. And I think there was someone that I was interviewed that described the sort of medical system as very siloed. And I think that's exactly what you were just describing, wasn't it? Where you've got your heart specialist and your lung specialist and your bladder specialist, and none of them tend to speak to each other. So it just makes it very difficult when you've got a condition that encompasses all of these things because you're punted around specialist to specialist to specialist, which isn't hugely useful.
Yeah, I think that some long COVID patients have a single organ problem, where they just really have a respiratory problem and they need a good pulmonologist. But I think a majority of long COVID patients, particularly people who are still sick at 6 to 12 months after their infection, these people have a systemic disease that requires comprehensive thought processes, right? We're not going to fix the lung and fix the heart and fix the whatever. We have to think of what is making all of this go wrong and how do we comprehensively help this patient. And so that's what we've been pushing for with the long COVID clinics, because as I'm sure your listeners know, they come in varying qualities and characteristics, right? There are some long COVID clinics that are really great, and there's others that have popped up that really don't seem to know what they're doing and maybe aren't learning as much as we'd like them to. And it's very frustrating, I think, if you land at one of those clinics and they're just taking that one organ at a time approach, But in terms of dysautonomia, autonomic disorders, even before COVID, 50% of our patient population was post-viral in nature. So we didn't call it long influenza or long Epstein-Barr or long mycoplasma, which might be what I have, right? That was my initial infection a month before my concussion. We didn't call it long, infection name, but a majority of our population was post-viral in nature. And so seeing long COVID clinics pop up is actually really amazing. This is wonderful, even if they're not perfect yet, and so we're hoping that in addition to learning how to treat long COVID effectively and giving good clinical care, we want these clinics to also understand that there's this whole world of other people that were around before COVID who had pretty much the same exact thing and were just not being paid attention to by the medical system in any meaningful way. So I would ask the long COVID patients and doctors who might be listening to, yes, obviously you're understandably focused on long COVID advocacy right now, but I think we need to build a bigger tent and put all of the different disease communities that are advocating together for, post-infectious conditions need a home. We don't really fit in any one particular discipline. So I think the more of us advocating together for better post-viral condition care, because sadly to say the truth, COVID isn't going to be the last virus, it's not going to be the last pandemic, right? It's the first one in our lifetime, but there's going to be other things that like this happen in the future. And we need our healthcare systems to be better prepared to handle large waves of people with post-infectious conditions.
Yeah, exactly. I literally couldn't have put that better myself, despite trying to the other night. It's like, these conditions did not spring up as a result of COVID. They all existed beforehand. It's I guess the sheer number of people all at once that's maybe brought some of them more to the fore, which hopefully, it's not a good thing. It's obviously not a good thing. But like you say, hopefully it is a platform for everybody to work together, because that's what we want, right? Isn't it?
Yeah, I find myself being angry on behalf of long COVID. Like if we had properly studied POTS and other types of dysautonomia and chronic fatigue syndrome and stuff like this before COVID, we would know how to treat long COVID much better than we do. So that failure for government agencies and pharma and academia and I don't want to paint everyone with the same brush. There certainly were people in pharma and government and academia who were doing good work for these patients before COVID, but it was a very small minority of people. And so the fact that we didn't do that is now why we have millions and millions of people around the world with this post-viral illness that we don't really have great tools. We have some tools, right? It's not a complete. Actually, I wanted to touch on this if you don't mind. I hear a lot of media and even doctors saying, oh, there's no treatments for long COVID, right? So there's no government approved formal clinical trial, FDA or EU approved, but we know if you have long COVID dysautonomia of some sort, long COVID POTS, long COVID orthostatic intolerance, we know how to treat that because it's just long COVID POTS is POTS. These long COVID folks might have other stuff, right? And you might have, in addition to POTS, you have a respiratory problem because you maybe had some lung damage from the virus, or you have a particular fingerprint or imprint of COVID might be a little different. And you could say that about any virus probably, but we know how to treat post-viral POTS. We don't have a magical cure for it. I don't have a wand that makes everybody better tomorrow, but we have tools, and there's the more tools in the toolbox that you have to treat your overall health problem, the better. So I really want patients who are advocating for themselves to get care to know that if you're lightheaded, if you're dizzy, if you have a racing heartbeat, if your blood pressure is way too high or way too low, this is a type of dysautonomia, and we have tools to treat autonomic dysfunction.
We'll be right back. Hey there, I'm just jumping in for a second to see if you're enjoying this episode. If you're finding it useful, maybe you would consider sharing it somewhere, a friend, a group, or even on your Twitter feed. If everyone was able to share just once, we'd be able to get this information out to even more people who really, really need it. So please consider sharing somewhere if you possibly can. I hope you enjoy the episode, and thank you so much. Yeah, definitely. There's so much that can be done, isn't there? I mean, I've basically been hacking my way through this kind of by trial and error, and which I think is probably true for quite a lot of people, because there wasn't really much help out there, and of course I went and did all the wrong things first, but since I kind of worked out what it was, it's literally been kind of like, I'll try that, but it has been very much kind of trial and error, mistakes all over the place. So would it be possible to kind of talk through some of the things that can help, or is that a bit too sort of wide of a question?
It is a wide question, but there's some general concepts. If you have long COVID POTS or long COVID orthostatic intolerance, or even long COVID orthostatic hypotension, well, my first piece of advice would be actually try to find a doctor who has some expertise in autonomic dysfunction. Our website lists doctors in countries around the world, dysautonomiainternational.org/doctors. A shorter website to remember, because I know long COVID folks are brain foggy, just like POTS patients. curepots.org is an easier site to remember. And that's the same website. It goes to the same place. And we have find a physician. And then we also have support groups in all 50 states and 60 countries where you go on the support group. Each support group has a list of helpful doctors, and everything from this gynecologist is dysautonomia savvy, this dentist, rheumatologist, cardiologist, etc. Patients advising other patients on who's good at this. So get a good doctor. But the reality is the wait lists for the top experts in this are very, very long. So a big piece of dysautonomia treatment is self-management type things in addition to medications. You really do need to do both. Most patients need both. So the standard self-management stuff that a doctor would recommend after they've diagnosed POTS or orthostatic intolerance would be increasing your salt and fluid intake. So it's not just, drink a little Gatorade or something like that. Standard recommendation would be 3 liters a day of hydrating fluids. So coffee, caffeinated tea, and soda and alcohol don't count. So you can't have 4 mojitos a day and say you've met your hydration needs. Sorry.
Darn it.
Yeah, darn. The fun thing about having POTS is you feel drunk and you haven't even had any alcohol. So 3 liters a day of hydrating fluids, and then 8 to 10 grams of salt per day, which is a lot, but I would say don't purchase. Some pharmacies sell 1 gram or 1,000 milligram salt pills. They're just straight up sodium chloride tablets. They will make you barf. It's too much salt at once, and they make a lot of people nauseous. So I would advise against that. if you don't have a lot of money to spend, as we know, a lot of people are struggling economically if they can't work or things like that, you can just do this with regular table salt on your food, But if you want, for convenience factor and just sort of helping you get to your salt goals, there are lots of kind of hydration salt products. We love Vitassium, and I will totally disclose they do donate to Dysautonomia International, but we're very selective in our corporate partners because we only want to work with companies that actually have good products. So we love Vitassium, and it was actually developed by some doctors at Johns Hopkins who treat POTS and chronic fatigue patients in collaboration with the company. So they're a really great product. It's called Vitassium, that has a lot of sodium in it. There's other like oral hydration drinks that are, there's tons of them available now. I don't want people to feel like you have to spend tons of money to be treating yourself appropriately. These are just things that are like really convenient, and you know exactly how much you're getting because you can read it on the label, so those can be helpful. You have to do the salt and fluids together. If you only do one of them, it's not going to have an effect. And the reason we do this is because people with POTS, and probably most people with orthostatic intolerance, have low blood volume. They actually are missing a quantity of their blood. And so when you increase the salt and fluids, you're increasing the plasma, clear, watery part of the blood. It doesn't increase the red blood cells, which are also low in these patients. But filling up the tank with salt and fluids is better than nothing, right? And so the primary way that we increase red blood cell volume in POTS is probably a little controversial in long COVID, because I think the jury's not out on how much exercise and when. But in standard POTS, the standard recommendation is that regular exercise is really important. And the reason why is because it helps build your blood volume, your red blood cell volume. So I caution patients to just go at your own pace. Sometimes you have a feel good day where you're like, oh, I feel good today, I should go for a run. Like, nope, you should pace yourself. You should try to get whatever your level of activity is right now, trying to super slowly at your own pace, and don't overdo it. And if you do overdo it, forgive yourself, right? You're learning as you go with this. I'm 12 years into this, and I still overdo it sometimes and learn the hard way. But I think whatever you feel comfortable doing, you should try to remain as active as possible. The more you lay in bed, because you feel awful with POTS, right? You want to lay in bed. It feels awful. The more you lay in bed or don't get physical activity, the worse POTS gets. And we know this from research and from the lived experience of patients themselves saying, yeah, if I get a cold and I lay in bed for a week or a surgery, this makes POTS worse. So that's the do-it-yourself stuff. Also, medical compression stockings. So the most helpful, we actually have research now done by a POTS patient, I will add, who's getting her MD PhD, showing that abdominal compression is the most helpful place to have compression for orthostatic disorders, autonomic disorders. This is because most of your blood pools in your lower abdominal area when you stand up. Your feet might turn purple, but it's actually pooling in your gut. So abdominal compression, you could buy that at a medical supply store, but other people use things like Spanx. It's easier for women to find kind of like, those granny panties that are really tight and holding all the muffin top in, older women know what I'm talking about. Younger girls are like, what? But those really tight compressions, shapewear is what it's called now. But also medical compression stockings. Some people just feel like these are just too uncomfortable. I can't wear these. So they prefer like knee-high compression socks. And those are, there's some benefit to them. Certainly lots of waitresses and nurses and people who are on their feet all day wear those. There is some benefit to like really tight compression on your calves. But if you're really want to try, the most effective tool you need is full abdominal and full leg compression. So in the US, you can get these covered by insurance if your doctor writes a script for them. I'm not sure in the UK and other countries how that works. But so another thing would be getting good sleep. Easier said than done if you have insomnia or just sleeping at the weird wrong time of day, but good sleep health is really, really important, because even missing one night of sleep significantly disrupts your autonomic nervous system function, even in a healthy person. So those of you who are younger and still do the college all-nighters, that's not good for your autonomic nervous system. So if you already have a long COVID dysautonomia going on, you're going to make it worse if you're not getting good sleep. And it's worth it if you're having sleep trouble, reach out and try to find a sleep specialist. There's lots of different ways they try to manage and help people get good quality sleep. Diet, which is sort of always a big question mark. What should I eat? And so we have some research in POTS showing that carbohydrates increase POTS symptoms because it increases blood pooling in the gut. So I wouldn't say don't eat any carbs because that's not, healthy to be so overly restrictive, but trying a low carb diet and focusing your carbs on complex, healthy carbs like vegetables and whole grains rather than, junk food, like the processed food we all love, most of us love. Oreos are not good for your POTS, even though I love them. But whole grains are much better. And obviously, lean proteins and vegetables and stuff. I would say less on the research side, but more on the patient experience, eating an anti-inflammatory diet, which has omega-3, so salmon, walnuts, olive oil, like a Mediterranean style diet can be helpful to sort of reduce the inflammation that we presume most long COVID patients have, whether you have blood tests proving it or not. And then eating smaller meals throughout the day. So if you eat a big, giant pasta dinner, it's going to make your dysautonomia symptoms feel worse. And so we tell dysautonomia patients to eat smaller meals throughout the day, like be a cow and graze, and see if that helps. And if it doesn't help, with the dietary stuff, I'd say give it a try for a month. And if you don't feel any different, then don't go out of your way to do kind of excessive effort to put it. It is also, I want to recognize for patients that having to learn all these new lifestyle things and incorporating them into your daily routine takes time. And it feels really overwhelming in the beginning. So I would say do one at a time, and then you get into the habit of it, and then you add another one. Those are major lifestyle things. Medication wise, there's a lot of options for medications. That is really more tailored to your specific situation. So you need a doctor to figure out which one to try. But beta blockers are really common to slow down the heart rate if you have tachycardia. Too much beta blockers can make you fatigued and more brain foggy and lower your blood pressure. So there's this other drug called ivabradine or Corlinor. Corlinor is the brand name, so it might have different brand names in other countries, but ivabradine is the drug name. And this slows down the heart rate without dropping the blood pressure, and it doesn't seem to increase the fatigue or brain fog. It's harder to get insurance approval for it because it's more expensive. Midodrine is another one. This constricts your blood vessels to help push the blood back up to your heart and brain, which should conceptually reduce some of the brain fog, slow down the heart rate, normalize the blood pressure a bit. People also use Mestinon. So this is a drug that increases the parasympathetic nervous system side. And so it has a lot of different effects, but I personally think one of the most interesting effects of Mestinon is that it actually has an anti-inflammatory property to it. It stimulates the vagus nerve. So it does a lot of neat stuff. And I'm hoping that we're going to see some Mestinon clinical trials in long COVID. Mestinon can cause about 20% of patients get really bad diarrhea from it, so they can't continue it. But if you have GI motility that's too slow, Mestinon might be your new best friend. But it's definitely the kind of drug you need a doctor who knows what they're doing to prescribe it, because it's a pretty serious drug. Then we also have patients who take mast cell activation related drugs, usually starting with the standard antihistamines, over-the-counter antihistamines. So we don't have really any clinical trial research using these in POTS or orthostatic intolerance, but we do have a huge amount of patient anecdotal data saying this helps me, and so we need to have that formal research happen, but it's pretty benign to try an over-the-counter antihistamine and see if it helps. Take it for a week, But I want to make it clear there are definitely other medications. Like that's probably a whole, semester of medical school on all the meds we use for autonomic disorders. but I want people to know that they exist. There's options. If you're being told there's no treatment for POTS or there's no treatment for dysautonomia, it's because you're seeing a medical care provider who doesn't know what they're doing, at least on this topic.
Yeah, absolutely. And it sounds like your website is a really good place to go for, well, lots of things, actually. So I'll drop it into the show notes. So I'd say that's probably a really, really good place to start.
We have another site, longcovidresearchfund.org, which is part of Dysautonomia International, because there's such an overlap between dysautonomia and long COVID. And actually our research that we published with Stanford University found that 67% of long COVID patients have moderate to severe dysautonomia. So we, as an organization at Dysautonomia International, said, wow, we need to start funding long COVID research. So we've been doing that. We funded some studies looking at low-dose naltrexone, EECP, which is sort of, I always forget what the acronym stands for, but it's like this leg compression thing. Yeah, I'm having a brain fog moment, guys. But EECP, and then we also have stuff looking, you're the first to hear, we're just about to announce, we're going to be funding a long COVID POTS IVIG clinical trial, immunotherapy. And we're also funding a bunch of research looking for various autoantibodies and other immune markers in long COVID patients to hopefully design more targeted treatments that get to the specific immune mechanisms. So there's a lot going on. I know it's really hard living with a sort of a mystery condition, but there's lots and lots of good research happening. So have hope and keep chugging along. And I think eventually we're going to have good answers for these patients.
Yeah, that's amazing. That sounds like another 4 episodes just in the things you've just mentioned.
Sure. I'm happy to come back and talk about some clinical trials. And I think one of the things we have to do as a community is mobilize our patients and encourage them when there are clinical trials that are enrolling, really helping get people enrolled as quickly as possible so the studies can be done and published as quickly as possible. One of the biggest delays in research is difficulty enrolling patients. So I know that there's this huge community of long COVID folks that are like, put me in the study, I want the new drug, So we could, have another chat on that. There's so much going on there.
Yeah, that would be absolutely fantastic. Yes. Cool. Well, thank you so much for today. I've learned loads. So it's been an absolute pleasure for me. So thank you so much.
Thanks for having me. And thanks for hosting this for patients and providing this information for patients is so helpful.
Thank you so much to all of my guests and to you for listening. I hope you've enjoyed it, or at least found it useful. The Long COVID podcast is entirely self-produced and self-funded. I'm doing all of this myself. If you're able to, please go to buymeacoffee.com/longcovidpod to help me cover the costs of hosting the podcast. Please look out for the next episode of the Long COVID podcast. It's available on all the usual podcast hosting things. And do get in touch